Good morning, everyone. I have the pleasure of introducing our speaker today, Dr. Thompson, also a colonel. Dr. Thompson has a very impressive background. So she graduated from the Virginia Commonwealth University in Richmond, Virginia. She then went to medical school at Eastern Virginia as well as Medical College of Virginia, now called Virginia Commonwealth University, I believe. Then did her internship at Madigan Army Medical Center in Fort Lewis, Washington, and then finished her residency at Brooke Army Medical Center in Texas. She will be talking to us today about team steps, and she also provided, I think you guys provided breakfast as well. Thank you very much. So very appreciated. So I'd like to introduce Dr. Thompson.
Thank you. Working. I'm hoping that the volume will be okay for this. I'm not exactly a high-tech person, so some of the stuff in here is, complicated. Where I have to switch between videos to keep you all entertained because I don't know how you're going to stay awake otherwise. But I do represent Army medicine, but I'm also a civilian at the facility that I'll introduce to you in a second, and I just call this Teaming Up for Quality Healthcare. But it's really about team steps. Anybody here heard of Team Steps, the Team Steps Initiative for Safety? Shaking your head, yeah. So we have that now, just now, at Womack Army Medical Center where I work. And so today I have to introduce you to the topic, and we're going to define what a high reliability organization is in the setting of healthcare, and what the Team Steps Initiative is for safety and quality, and how it can help you in your OR and your L&D setting throughout your career. If this institution ends up not adopting it at any point, wherever you work may well want to. It's or something like it, okay? And we have it now, just now, at Womack Army Medical Center for a reason, because I'll describe to you why we introduced it a little quicker than our timeline was going to be. So that's where I work, that background there. Womack Army Medical Center, I'm a civilian there, but I'm also a colonel in the Army Reserve, so it's like a part-time job, almost like a locum tenens for me. For the last almost 15 years, I've been doing that. And I got this job as a civilian 6 years ago. I got out of private practice. The climate of healthcare was changing and everything, and I just wanted to do gynecology, and I really loved the military setting and all the people taking care of them and stuff, their dependents and active duty. So I applied and got a job at this facility as a civilian. And that's where I am now. We just started a residency program there. We are graduating our first class in 2016. That's really exciting for us because when I took the job, I was just clinical. I wasn't having anything to do with residency, but I love you guys. And I just want to say to you, you're awesome. I looked you up, okay, just to see who was out there. And man, you are impressive, really. I did a bio on you, and I have a dossier, and just kidding. But no, there's somebody here that went to my school, Virginia Commonwealth University, Medical College of Virginia. Anybody in this room claim that? No claims. And then there's somebody that went to Duke here, because that's kind of in my neighborhood. No Dookie? Oh, you're claiming it. Okay, Blue Devil thing, but you're not wearing blue. So I'm wearing blue. This is an Army uniform. I get mistaken for either a bus driver when I'm wearing my hat, or U.S. Air, American Airlines, because of the birds on the shoulder. I can fly, and if I stay in a Holiday Inn Express, so I can fly a plane. So anyway, so that's what's going to keep you awake is some animations. All right, so who's my indirect boss? Lieutenant General, that's 3 stars. Patricia Horho is actually a nurse, Army Nurse Corps, and she's our Surgeon General. She's not the U.S. Surgeon General. But her big initiatives was culture of safety and to sustain it, okay? So create a culture of safety in our institutions. We have very many medical treatment facilities across the Department of Defense, all right? Why do you care? You're in a civilian, you're here, you're in your scrubs. Because, sorry, because ACOG cares and every place you work is, or plan to work is going to care. All right, patient safety is huge, and this is just demonstrating a Disney Yacht Club Resort Orlando Patient Safety Conference in 2015. That's coming up in November, I think. So it's a big deal. Okay, it's not just the Army's doing this because it's everywhere. It's a civilian deal too. So we want to be a high reliability organization. That's our goal for our institution, and we hope that other, especially the large medical centers, will keep that. But why now for WOMAC? Why am I here standing talking about it? Because Gandalf says, we got in the fire. We were not in a good way in the New York newspapers for our medical center. We had a bad JCO survey, and it was at the time when the VA was having problems, so the media started to focus on us. We're nothing to do with the VA. We love them, but we're not them. And so we had to change what we were doing. We had to completely revamp how we feel about patient safety and quality. Okay, so that's where this comes out of. So we're going to be a high reliability organization, and it stems from, that concept stems from airline industry averting disasters, and I have a little video I'm going to show you in a second. So high-risk industries need to be high reliability organizations, and we have creative responses to failure. So Fran Tarkenton just published a book, something like The Power of Failure, something like that. And everybody was like, what kind of book is that? But he says, hey, you can learn from this. You actually don't learn. If you succeed every time, first time, you're not learning anything. Everybody fails somewhere, okay? But we can't afford to fail when it comes to patients, right? So we're focused on with failure. We're preoccupied with not doing it. We don't want to simplify how we look at systems and processes. We want to be sensitive to all the operations of our facility. We're committed to keeping this going, and we're going to look for the subject matter experts for everything we can. With superheroes in the background there, team training. This is what we're doing now at Womack Hospital is team training, mainly in our OR and our L&D, but all over the hospital, ER, all the clinics. And nuclear power industry, air traffic control, they have teams, and they share the same characteristics that we do in the hospital, okay? It's complex operations, lives are at risk, failure is devastating. So I don't know if any of you are Guardians of the Galaxy fans, but I am. So this is my idea of a team. It's made up of very diverse individuals, very diverse backgrounds. You never know who's going to be working with you in the OR. You never know who's going to be on your labor and delivery shift with you. And a disaster might happen. You need to be prepared for it. So you function using common language as a team. So the common language is what's going to bind you together. And this was a cute video, okay, with Minions, doing that whip, nay thing, but I can't make them do it. And the whole stanky leg thing, I can't make them do it. Quick time doesn't work on this. So what is it really, since it's not that? It's not Minions. It's evidence-based. They have a lot of data over 20 years with this, okay, system. It's for quality, safety, and efficiency. Things you'll see in the video vignettes, things really do work better when you use the common language, okay? And it's practical, adaptable to any institution. There's ready-made materials. There's like a flip pocket guide and a little card that fits in your ID that you'll never look at. And but in an emergency, it does help. The steps, leadership is important. We're going to monitor performance. We support each other, and the key is we communicate. Okay. It's comprehensive multimedia. Let's see, I'm going to have to click on this and pull it up. And I won't play probably the whole thing. guy's really loud when he comes on.
Team Steps is our innovative approach to implementing and sustaining healthcare safety throughout our organization. I believe Team Steps will allow civil and military medicine to work together to enhance safety in healthcare systems around the world.
These are some of their materials that they're just showing, that they use to train.
Communication failures and lack of teamwork are major contributing factors to patient injury and harm. And a growing body of evidence from the military, corporate settings, the transportation industry, and healthcare settings confirms the fact that essential team skills can be developed.
We do SIMS training a lot using this in our OB department.
Teamwork training is a change in culture.
You'll see some of these in slides in a second.
Concrete teamwork fundamentals can improve the efficiency of care, delivery, and outcomes for our patients.
Okay, for more information. There's a lot of training centers, actually, and Duke University is one of them. I just finished a 4-hour training last week, just as a refresher, but you see they're all over. LA, UCLA has one. And I just did a refresher training. It's basically 2 days, because we shut down our OR for 2 days to do this training in a big way. We all went and did scenarios in our OR, pretend, role playing and that sort of thing, and so that we could learn the language and talk to each other better. So the goal is to communicate, back each other up, always have our backs, and develop team skills, because they're learned and can be trained, and they're not innate. I mean, as doctors, we're kind of like, this is my practice, this is the way I do things, but when you're in a hospital setting, you really do need a team. So the team concept is something that almost we have to relearn as doctors. It's like, hey, we need that nurse over there, we need that scrub tech over there, we need that medical student over there. Okay, so I'm just going to flip through these because words are kind of boring. But anyway, we're just aware of team roles and responsibilities, and conflict resolution is key with Team Steps, because in fact, one of my residents told me that she just wouldn't feel empowered to tell the attending, hey, look, I think this is hurting a patient, if she didn't have these Team Steps concepts ingrained, okay? But she felt empowered, so it eliminates barriers, okay? And on labor and delivery, basically it has proven to reduce bad outcomes and also the severity of those outcomes. That's evidence we can actually show you, although at my institution we've just started using it, so I don't have data on my institution. As I told you, our OR actually shut down for 2 days to really go through this with each doctor and nurse. Everybody, scrub techs, everybody did this training all together, and they showed that it actually improves the parameters that they looked at for care, things that we care about, getting those antibiotics in, doing that DVT prophylaxis. So in the OR, it's going to help with error avoidance, and you do the timeouts. So this is kind of an expansion on timeouts, right? And nurses love this, because we all start to sing off the same sheet of music, and they don't feel like they're left out. All employees feel like they have better job satisfaction when institutions are using Team Steps. They feel empowered. So that's a big word I'm going to use a lot, empowerment. So your institution has to define the need. I just told you why ours needed it, and we've been implementing it just now. We're starting to train and implement the strategies, and we're looking forward to sustainment. So we're planning on using this as long as We need to use it forever and ever. And we probably didn't fill out one of these questionnaires that just asked questions like, I don't know if I can't point them out, but questions like, you know, are you having problems? Does your institution need this? I mean, duh. You know, so I don't know if that's going to play or not. We'll see.
You don't know the power of the dark side.
Okay. So why are haters going to hate? There's resistance within our institution. We have doctors who say, I'm not liking this, you know, and then the institution hierarchy says, no, you will do this. Trust me, you'll like it. Because everybody's doing this, so don't be a hater kind of thing. But you have detractors always, okay? Anytime something's new, it's going to meet resistance, all right, in any institution. But ACGME, they kind of like team concepts, team training. American Association of Medical Colleges, they like team training. National Quality Forum, they like team training. Joint Commission, oh my God, they like team training. Holy cow, they really love it. All right, Medicare and Medicaid services. So everybody's into this whole thing. And the top of the ladder on this whole deal is that you have to have leadership in your institution and within the teams to get this job done. Situation monitoring just means, you know, you're going to become aware during the Team Steps training of what's going on around you and be able to monitor your environment to see if you need to make a change in what you're doing with a patient, with a procedure to get a better outcome. You're going to support each other and communicate with each other as part of the Team Steps. And the curriculum, it's like multimedia, like I've already shown you one of those government videos, all right? I had a better one, but it's in the interest of time, I bagged that. But maybe I'll show it later if there's time. There's modules that we go through. Like I told you, I just did 4 hours of this. But it wasn't boring because it was interactive. We were all engaged in the whole deal, okay? I am not going to make this interactive for you because you will be like, please. You could do that another day. But there's a whole bunch of DVDs, or rather, a whole bunch of video vignettes that I'm going to show you off of my DVD from their website. So leadership really is the key to this, and we've got to get the institution to buy in, but then we have to get individuals within the institution to buy into this, and those were Dwight's words. Had to throw the Army in there somewhere, you know. All right, so team leadership can take different forms. You can have various, you know, makeups of your team, and team leaders might change. I'm a Lord of the Rings fan. I'm sorry. What? But sometimes Frodo will lead and sometimes Sam will lead, okay? So there's types of leaders, designated and situational in effective teams, and I think you can figure out what that means. Like when you're in the OR, the designated team leader is usually going to be the attending surgeon, right? But they may hand off to the resident. They may hand off to the resident. So it's whoever can best manage the situation, all right? And how to be effective, you make your goal known to your team, and we're going to go through some of that really briefly. And it's a collective thing. I mean, the whole point of a team is that you don't have a dictator. There's not somebody saying, this is the way it's got to be. You know, everybody gets a little chance of input, and that's what makes Team Steps so powerful is people buy into it because they say, hey, man, I got a voice. I'm just a scrub tech, but I have a voice in this. It's when appropriate, obviously. The scrub tech's not going to tell you how to take that uterus out. Well, they might. I don't know. But, and conflict resolution is part of that. So you got to have somebody you can follow. And so, I love him. All right, sorry. It's a Hollywood thing. And you're in California. All right, albeit Northern California. So communication is the centerpiece for Team Steps. The whole deal, it wouldn't work if we didn't communicate using the same language, okay? And you know if you miscommunicate in the OR, you're going to drop the freaking patient on the floor, and it's not good. And anesthesia is going to blame the medical students in the back. You didn't do that right, guys. All right, JACO says, please get this right. Communication failures, that's number one. I mean, you know, that's what harms patients. And drills for things for in your area would be emergency C-section drills, shoulder dystocia drills, oh man, hemorrhage, you know, that random amniotic fluid embolus, all right. That happens. We actually do this. We do it with mannequins. We have high-tech mannequins, and you probably have Sims, right? Do you have Sims? Sims labs, you know, and you practice your skills. I didn't have that when I was growing up, right? I had just real people who were like bleeding out. So I'm so glad you are in the era of high-tech. I don't want to tell you how old I am, but it's wickedly up there. All right, so briefings and debriefings, we'll go through that. So communication centerpiece, and there's just some more statistics, boring. But sentinel events, hey, nobody wants that, right? So Stewie says, but of course. All right, so this is. I'm not going to go through the whole video on this. You'll get the gist of it really quickly.
Oh, hi, Dr. McCarthy. Do you have a second?
A second?
Sorry, I just wanted to talk about Mrs. Holmes.
What's up?
Well, I spoke with nursing after rounds today. I was wondering if we should change her pain medication.
I'm sorry. Who are you?
Oh, I'm John, the pharmacist on the stroke unit, while Tanya's away.
Why change your medication, John? Why wouldn't we just up the dose?
Well, the current med isn't fully relieving her pain, and the team says it's making her drowsy, too tired for her therapies. She's reporting her pain at 7 out of 10.
All right. He's losing her now.
Okay, what are you suggesting?
What? What do you want?
Well, I don't really know this patient very well.
Shut up. Okay, so yeah, get out of my face. You don't know the patient? What are you talking about? So he has lost her. He has done nothing for his patient, and bless his heart. All right, so, and that's what we say in the South. I'm from the South, sorry. So you've got to be clear, concise, timely. Make it. This is for the medical students in the back. Why did I make y'all sit back there? You should be right here. So the nursing folks know this S-bar thing. I don't know. Do y'all use S-bar at all? You use S-bar? Yeah, it works. And we'll show you situation, background, assessment, and what do you want? I'm going to show you better.
Why are we making a federal case out of this?
Because it's important. All right, so here's a better way to do it. Same two people.
Hi, Dr. McCarthy. Is this a good time? I need 3 minutes to discuss Mrs. Holmes. I'm John. I'm providing pharmacy coverage to the unit.
I have a few minutes. What's up?
Nursing raised a concern from rounds this morning. The situation is that Mrs. Holmes' pain isn't being well controlled. She's sedated, which is having an impact on her participation in therapies, and she's continually reporting her pain at 7 out of 10. Now, the background is that she's fallen 3 times since her admission to rehab, and she's requesting to go home at her first pass this weekend, some big family anniversary. But my assessment is that we are not adequately controlling her pain, and what we're giving her is contributing to these falls.
Okay, so what do you recommend?
Well, after reviewing her chart, I'm considering lowering her dose of opiates.
Now she's given him credence because he's credible. Okay, he's credible now.
Yeah,
that makes sense.
Her husband is coming in this Thursday at 10. If you're available, we could...
All right, enough of that. So yeah, the difference. I mean, this is real, you know, because you live it. You know, you're the one on the phone, and the nurse is telling you something. You're like, wait, what? I'm not awake yet. Give me the freaking S-bar. So, I mean, our people walk around with this stuff in their pocket so they could remember, you know, until they get it down, right? So, what's the cuss? We use this a lot. Our residents love this. They love to cuss at the attendings, okay? This is how you stop a bad thing from happening. And it basically, do's would be you articulate your concern. I'm concerned. I'm uncomfortable with what's going on, Dr. X, and I think it's a safety issue that puts the patient at risk. It does not mean that you curse at and you throw things at people, but you know, so it prevents that degeneration. Anyway, so we keep this in front of us at all times, and our residents use it against us or for the patient, and we appreciate it. They feel good about it. And again, the confrontational part of that doesn't come up because we're all using the same language, and they start to even joke about it, but we all know that it's not a joke. So let's see. Forget. Let me play this and see what it is. Oh, this is good. Yeah, I like this. You'll enjoy it. You might have seen it before.
requesting that you immediately divert your course 15 degrees to the north to avoid a collision. Over.
Please divert your course 15 degrees to the south to avoid collision.
This is Captain Hancock. You will divert your course. Over.
Negative, Captain. I'm not moving anything. Change your course.
So, this is the USS Montana, the second largest vessel in the North Atlantic Fleet. You will change course 15 degrees north, or I will be forced to take measures to ensure the safety of this ship. Over.
This is a lighthouse, mate. It's your call.
That's the Navy, okay, not the Army. Anyway, that's, yeah. The first time I saw that, I was tickled. Okay. So team events, there's 3 major categories. The brief, where we plan things. That would be like your timeout. Okay, sort of like that would come under that heading. A huddle, whenever there's a problem. You know, whether it's on labor and delivery, and it's an ad hoc. It's like people get together because all of a sudden something's changed and they need to get a new plan or modify their plan. And then a debrief, what did we do right, what did we do wrong? That's more just an exchange so everybody can learn and get feedback, and it's supposed to not be like M&M where you get finger pointed at you, you did wrong. You know, that's not supposed to be like that. So anyway, the brief, this is not an OB scenario. I have one later, but this will demo it.
Here's what I'd like to do. I'm going to bring the baby over, put the baby on the bed. Kim, I want you to listen for breath sounds.
Just giving them their orders for what to do.
And Bergen, if you'll just grab the umbilical stump and palpate for a pulse and let us know what the heart rate is as we're carrying this out. Okay?
Everybody's clear. Everybody got a chance to go, wait, you know what? So I don't feel like you probably need to go through all that. But.
This is important. Once the battery is removed, everything is going to slam into emergency.
This is an alternative brief.
Once we have it, we got to move quickly. So you definitely need to get that last.
So, did anybody here watch Guardians? Yeah. I love that movie. All right, sorry. I digress. Never mind. So the huddle. This is another non-OB scenario demonstrating a huddle.
Here's his electrocardiogram.
Oh, this looks like it could be acute MI. All right, everybody, hey, let's huddle up before we go in so we know what we need to do.
Well, Dr. 4 liters O2 by nasal cannula into asthma. He's hypotensive, so we might want to drop the nitro. He's already on the monitor.
Good catch, Karen. Hold the nitro. Where are his cardiac labs?
His labs are pending. We should have those in 15 minutes.
Let's prepare to get into the cath lab immediately. I'll call the cath lab.
Okay, so everybody has a job. Everybody's clear about what they're going to do. So that was like an ER scenario. The debrief. I'm going to click on this, but I'm thinking I'm going to show it at the, yeah, never mind. We're going to do that in a minute. Okay. So there's another way to debrief in the bar later. Another aspect of team care, situation monitoring, because, you know, medical care is dynamic. It's a changing thing from moment to moment. You got to have the status of the patient in the OR that, you know, maybe anesthesia says, hey, she's dropping her pressure while you're pulling and tugging on her peritoneum. Can you stop while you're packing her bowel? You know, can you please stop because I need to control her pressure? So that would be, you know, a status of the patient moment. The team members might change. You might have somebody scrub out and another person come in because they, well, this happened to me. I had a bladder stone. I had to go, okay, I have a bladder stone. I have to leave now for just a minute, come back. All right, progress towards the goal. Are we getting through this operation or this delivery or whatever? So you have to be aware. They actually teach us this in the military. This is kind of a military thing, situational awareness. But, you know, women all the time, we go out in the parking lot, so they tell us, you know, when you're at night, go in your car, you have situational awareness. There's nothing different in your job setting, okay? So it's just knowing and realizing and being aware, not looking at your phone and looking up and saying, oh my God, that guy's going to attack me. Hopefully not. So it's going to reduce error when we all work as a team. We empower the nurses to say, hey, that's the wrong dose, or, you know, that's not going so well, doc. You want to change what's going on? Or if somebody is getting sick, I had a scrub tech who was literally just looking green behind the mask, and I said, you know, why don't you trade out, because you're getting ready to throw up on the patient, so that's not good. Anyway, so we assist each other when somebody's going down for whatever reason, might be physical, might be mental, they might not have slept. We protect each other, okay, from work overloads and you guys, you know, the battle buddy system works for you too, to look out for each other and offer assistance so that the patient will be safer, foster a climate where, you know, you don't feel like a heel because you crapped out on that, whatever that was, that duty, and you ask somebody else to fill in for you. Don't do it very often, though. And then give each other a pat on the back, for crying out loud. So I had to put an Ewok in there somewhere. If you have Darth Vader, you got to have an Ewok. It's the fuzzy thing, you know. So what happens, though, when, you know, things aren't going well and you say, hey, things aren't going well, and the person's not listening. You tell them twice that you think something's not going well. You're not sure. You don't like it. You tell them you give them 2 tries. And then if nothing good happens, you have to take a stronger course of action, unless it's the lighthouse, and then you don't want to. You might have to go up the chain, you know. You might have to talk to somebody who's higher level, okay? And this video, this is, I'm sorry, it's from Grey's Anatomy. And so, but apparently they featured this in one of their episodes. Gollum is coming, but okay, so.
Any further, you're going to move into segment 2 and 3. And it will be fine. Won't be enough functioning liver to support this. I can get Neil and I will stop before MTV.
Prep one damn floor can now you think you're Moses.
Ellen, I am in the middle of dividing this kid's liver, and I need this conversation to be over.
Oh, you going to full rank on me again? Is that how the decision's made?
Use the 2 challenge rule. Dr. Webb told us about the 2 challenge rule, which
There it is.
surgeons use days before third surgery to stand out from the course of action.
Okay, fine. So, Dr. Edwards, you and I challenge Dr. Perez to relax and let me finish.
No, I'm challenging you there. I'm asking you to stop what you're doing.
Drama.
Edwards?
Oh God, what do I do?
You are amazing, and you made a beautiful choice, and I am so grateful.
The patient is dying.
Right now, I think you're pushing it. I have to second that.
She has no eye protection. None of it. So she just throws the instruments in the patient. Okay, but that was, you know, Hollywood. But it demonstrated, you know, the concept of the 2 challenge rule. So I don't know that any of our residents have really articulated that they've used that, but I bet they have. So there's other tools, and the video vignettes. Gonna do that. A call out, like you'll see in a minute, a nurse literally calling out into a hallway to say, hey, we got a problem here, and then a check back, which just closes the loop where somebody says, yes, I hear you, I'm coming to help you, or I'm never going to help you, or something. So you restate what you need, okay, or what is needed. So there's an OB scenario that actually we saw this for my department. I think there's other scenarios out there that they put together for different types of specialties and units, okay. But this is an OB scenario I'm going to run through, and this is what takes the time, I hope. It worked before you guys got here. So, please work. All right, here we go. It has sound.
This is Michelle Key.
raise that.
And her urine temperature is only 36. Cervix is 1 centimeter dilated, 25% effaced, and -3.
The first blood pressure in the clinic today was 141/88. The repeat was normal. We'll need to keep an eye on her blood pressure. She could be developing preeclampsia.
Let's run a type 1 screen and a CBC. We need to check her liver functions and uric acid level. Dr. Upton wants us to start an induction as soon as possible. I think that's 100 micrograms.
Can y'all hear that?
That's right, 100 micrograms.
Jen, who's coming in for you?
Well, there's subtitles. All right, I'm going to let this continue to run here.
Hi, Dana. I am late to pick up my kids at the sister, so I need to make this quick. We have a 27-year-old prima gravida who's had an uneventful pregnancy. She has been admitted at 41 weeks for induction with an unfavorable cervix. Poor thing has been waiting for a bed since early this afternoon and just got admitted.
That never happens. Right?
Right now, the attending is Dr. Upton. We're doing the stat section in room 15. Read your help. Ooh, patients are alarmed.
Right, I'll be right over. So nothing but the usual, right?
Right. Sorry, I'm in a rush.
Now, things are going south a little bit.
Dr. Baum, could you please take a look at the fetal heart rate?
So that's her call out.
Some late deceleration.
She's at 6, Dr. Dean. Think we should call Dr. Upton?
No, I think we can handle this without it.
Nah, he's sleeping. Oops. It's still going south. Come on, make a decision.
Dr. Dean, it looks like these decelerations are getting even more severe.
Dr. Dean, do you think we should consider C-section?
No, not yet.
No.
Anyway. This looks okay.
I feel his pain. She's challenging.
We need to do a fast check. Get up this way. Now.
So this is disorganized, not going well, not communicating well. Now all of a sudden it's horrible emergency.
Albert, Jim, I can't believe this. How long have you been here? This baby nearly died. What were you thinking? There's just no excuse for this.
That wasn't good for anybody. I didn't like that. I felt uncomfortable. Okay. So for a better, this is like done right. This is done the team steps way, this next bit. Same scenario. And Dr. Pham and Dr. Dean are still on duty.
Okay, so I spoke to Dr. Upton earlier tonight. He said Ms. Keys is a 27-year-old prima gravida at 41 weeks. Her cervix is 1 centimeter, 25% effaced, and -3. Her first blood pressure in the clinic today was 141/88, but the repeat was normal. He wants to induce labor with this quick radical. I think he wants 100 micrograms.
Catch that.
Actually, Dr. Dean, I see the order says 25 micrograms. That's impossible.
Yeah. Oh.
Fine. Just 25 micrograms. Good catch, Dr. Pham.
So he empowered the intern. I mean, if the intern hadn't felt comfortable contradicting his resident, you know, he might have just said, I guess he's right, instead of Googling it and seeing that the correct dose, right? You know, he might not have spoken up, and you never know.
But I'll review her technically and check back with the team. We need to keep an eye on her blood pressure. Could be developing preeclampsia. Janet, who's coming in for you?
I'm handing this case here off to Dana Pham.
So they're going to change teams,
You're concerned with her potential to develop preeclampsia.
and they're going to hand off the information. So this will go better.
Hi, Dana. I am late to pick up my kids at the center, so I need to make this quick. Doctors Dean, Pham, and I just had team huddle on Miss Keith. She's a 27-year-old prima gravida who's had an uneventful pregnancy. She's just been admitted for induction at 41 weeks with an unfavorable cervix. Poor thing has been waiting for a bed since early this afternoon and just got admitted.
That long, huh?
Yeah. She's stable right now. Dr. Upton's the attending. Doctors D and Palmer on service for her tonight. The plan's to induce by 25 micrograms and be supposed to go intravaginally. Oh, and there's something you need to be aware of. Her blood pressure was elevated in the clinic.
That was a really good handoff.
Normal here, so we just need to keep an eye on it.
We're doing a stat section with the team. I need your help moving the patient to the OR. Couple right there. So I'll keep an eye on the pressures. It looks like I got to run.
So, same deal. Although she didn't get that 100 micrograms, so she's probably a lot healthier. Baby's probably a lot better off. So she's calling out. I didn't hear anybody check back, though.
She's at 6, Dr. D. Maybe we should call Dr. Arch. It's early yet. I think we can manage this without it.
Okay.
Dr. D, I'm concerned about
Challenge.
I'm comfortable watching these late decelerations.
Cuss.
The heart rates in the 60s. I mean, I just don't think it's safe to continue labor.
Concern, uncomfortable, not safe.
Okay, then. Let's face Dr.
She convinced him. Yay!
Okay, she currently only has intermittent late decelerations. These have improved with her position changes to supplemental oxygen. Monitor her until she's fully dilated and allow her to push. If there's any evidence of fetal distress or persistent late decelerations, we should be prepared to go to C-section.
I've alerted the OR to be prepared in case we need to use it.
Great. I'll discuss this plan with Mrs. Thompson when done here. What are her vitals right now?
Normal, just checked 15 minutes ago.
She's had no late decelerations since the call.
Continue to monitor her. I need to know when she's complete and pushing so we can keep a close eye on her second stage. Any questions?
Okay, they did it right. And so she's now at the end. The very end of her labor. Plan has to change.
Hey folks, we're going to do a C-section on Mrs. Keys because of persistent late decelerations, which have temporarily improved. Mrs. Keys is a 27-year-old prima gravida at 41 weeks. Grant, do you have anything to add?
No additional anesthesia risk. I'm loading her right now.
So this is like a surgical timeout then.
She's almost ready for first treatment.
Lynn, is Keys on standby?
Speech has been called. They're on their way. I've alerted Linda to charge nurse tonight. Can we do our surgical timeout now?
Go for it.
We have Michelle Keys, ID number 45623901. She's consented for a cesarean due to a non-reassuring fetal heart rate tracing.
Lynn, we do have a Michelle Keys, ID 456-23901 for C-section.
Mrs. Keys, as a part of our safety check, please tell me while you're here.
Get the baby out. This is a better debrief, too.
What did we do well in working with you?
No yelling.
It was helpful for me to be brought in early. That allowed me to use a regional instead of a general anesthesia.
You're right. Lynn, what did you think?
It was great that Dr. D went with the phone in place while I did the count Felicia.
Albert, this is a great example of past assistance. How was our communication today?
Except you put the Foley in the vagina. Jonah's birth! No, go away, Jonah! Be gone! So we did the call out, and we did the cuss, and we did the debrief. Do y'all want to watch that? No, I'm just kidding. Teasing you. Okay, so high reliability organization is very desirable, and it's a goal for anybody that wants to be a center of excellence, and safety and teamwork are part of that. It has to be ingrained in the culture, and Team Steps is just a framework to put all that together. It's just one thing that has been developed, and all the the tools of the trade, okay, videos, whatever. But you can't video leadership into a person. So that's an essential component. But everybody in this room is a leader by definition, because to get where you are right now, you have to have some of those qualities ingrained in you, and communication skills also. You couldn't have come this far without being good communicators. With that, I will
And that was without even a single drop of rum.
conclude. Does anybody have any questions about Team Steps, the concept, the training, the Anything. Don't you want to do it now? Just run right out. Oh. Yes, ma'am.
How do you get some of the, like you said, some people are really into change, some people lag behind. How do you get everybody on board with something like that?
It has to be the top down. It has to be, that part has to be a buy-in from the highest levels of leadership. For us, that's why I showed that picture of Lieutenant General 3 stars, Jorge, because she basically looked at all of us and said, you got to do this. This is not an option. So somebody at a corporate level or an institutional level says, we need this. And they go through their little checklist on the website and say, wow, this, yeah, we got that. Yeah, we need it for that. Yeah, this would be good. And it has to be an institutional buy-in, but it can also be a departmental buy-in. So you can do this in smaller degrees. It usually would be helpful to include OR and labor and delivery into that. And the clinics are more optional, but it's good if the institution will buy in to the whole deal. It just works better when everybody feels the same empowerment to speak up when there's a problem. They're using the same language to describe what's, and nobody feels threatened then. And this really does work. I had a nurse midwife tell me last week, because I quizzed her, I said, how's the Team Steps thing working now that you all implemented it fully on labor and delivery? And she said, I witnessed a scenario where one of the, I think it was a nurse, it wasn't another midwife, but one of the nurses just, had to say, hey, I'm not happy with this, I'm not comfortable, and they used the cuss, and nobody was offended. I mean, because it's a cuss, that's what it is, and they never get to that two challenge rule, which is sort of, it's confrontational, but when you're using the language, that's not even confrontational. They just made it look that way on Grey's Anatomy,
How long did it take your institution to get on board?
Wow, let's see, we started this process. We closed our OR for 2 days in March to really just, we were pushed though. We were pushed to do that because we'd had a Sentinel event, all right, full disclosure, right? So, nobody wants that, and we all bought in. At that point, we're like, okay, we should have done this already, but we're doing it now, and we are totally committed to patient care, quality care. We don't ever want to have to apologize for bad care, okay? Because we want to do all the time the best that we can do. Stuff's still going to happen. We already know that. And would Team Steps have fixed what happened to us? Actually, looking back from my view, no, but it's always good to take steps. And the patients want to know, hey, something happened to me. Are y'all doing anything to change that? Are you fixing it for the next person? And you can point to these safety measures and say, yes, we at this institution are so committed. We went this far. We closed our OR to do training. Nobody does that. I mean, that is so hugely expensive. But the Department of Defense said, do it. We'll take the hit. We'll just do it. Make sure this gets in your institution. And just now, that was March, so just now, there's on my emails 3 invitations to Team Steps training, a 4-hour version classroom. And then following on to that, there's scenarios training that you do. Actually, you're interactive. You are physically in the room, like gathered around a patient with a team, going through the motions to prove that you actually can articulate what you've learned in the classroom, right? So we're at that point with our institution. We're in the full integration phase. But it's taken that many months since the spring till now. And still there's isolated pockets of resistance. The haters, that's why that slide is there. Because, every now and then I'll come up on a doctor and they'll go, Team Steps, whatever. And I'm like, no. No, shut up. I mean, you better do this because we're all doing it. And if you're that outlier, you got to have the buy-in. And actually, peer pressure, they buy in. Eventually, they cave, and they go, okay, I'll cuss. Anybody else? So was this helpful to you at all? Was it entertaining? Because there's more. Anyway, thanks. I'll let that run. Got music. You can hear it.